So I'm Grace, and I chose to do cardiac bypass today. So the more scientific name for cardiac bypass is coronary artery bypass grafting, or CAPG. This is defined as open heart surgery where a section of blood vessel is grafted from the aorta to the coronary artery to bypass the blocked section of the coronary artery, and it's seen here on the right. And nearly 500,000 of these procedures are performed each year in the United States alone. So now I'm going to talk about the history of cardiac bypass. So before I start, angina is a type of chest pain caused by reduced blood flow to the heart. So in 1899, a guy by the name of Francis Frank had the first surgical treatment for angina, which is ligation of the sympathetic pain pathways. So basically, he would close off a pain pathway, and then the patients would end up not feeling the pain that they were having before. But this wasn't actually solving the problem because you just wouldn't feel the pain. So groups started performing this surgery, and while it resulted in relief, the mortality rate still remained high because the consequences of the underlying coronary artery disease continued. So then they started looking at reduced myocardial perfusion, which is low blood supply to the heart, and they started to perform experimental surgical techniques. So in 1903, Thorel suggested that pericardial adhesions to the myocardium could provide blood to ischemic areas. So, and this was confirmed in 1932 by Moritz. So basically what they would do is they would use an irritant to perform a pericardial abrasion, so that's scraping or tearing away at the heart. And then, like when you cut yourself, what comes to, where you cut yourself, blood comes to it. So when he would perform the abrasions, then blood would flow to the ischemic areas. But again, this was just like putting a Band-Aid on the problem, because while blood would come for the time, it wasn't actually like clearing out the blocked artery or circumventing around it. So then they decided to start doing pericardial abrasions, but actually pairing it with collaterals. So if you've ever seen a picture of the heart, there's big vessels and little vessels on the outside of the heart. The little vessels are called collaterals, so they're the heart's backup system. So when your heart's under duress, they can dilate and have a greater increase of blood supply. So with this method, they were performing an abrasion, and then they were taking different parts from the human body and suturing them to the myocardium to perform the first kind of graft. And so some of the tissues that they used were the pectoral muscle, parts of the stomach, parts of the intestine, and the lungs, and then they'd suture it to the myocardium. And unfortunately, none of these actually worked. So then they started looking at the right internal mammary artery, and this kind of piqued interest as a collateral. So they started doing this in dogs, and actually 71% of the dogs with ischemic hearts would form an anastomosis, which is a successful connection using it. But then they realized that dogs actually have a higher percentage rate of forming collaterals, so it wasn't really a solution to the problem either. And the biggest problem they were having is while they put these collaterals in, they couldn't actually tell if the collaterals were working until the patient was dead, because they had no diagnostic tool to see that it was working. So the next major development was the development of the coronary angiography by Mason Soames. So this would actually allow them to place the collateral and then see if they were actually if the blocked artery, if the collateral was actually working. And so then these advancements finally led to the modern CABG procedure of the 1960s, and a guy by the name of Vasily Kolesov was the first to perform a sutured anastomosis of an IMA to the left anterior descending artery on February 25th in 1964. All right, so bypass machine temporarily takes over the heart and lung function during surgery. The purpose of that is so surgeons can work in a field without blood. So surgeons attach special tubing to a large blood vessel that allows oxygen-depleted blood to leave the body and travel to the bypass machine. And then the machine oxygenates the blood and returns it to the body through a second set of tubing. And the constant pumping of the machine pushes the oxygenated blood through the body. All right, so in cardiac bypass, the procedure begins with a sternotomy, which is performed. So they'll basically cut down the median line of your chest, as pictured here, and then they'll crack your ribs open to expose the heart. The heart is then connected to the bypass machine through the tubing. And then they stick a needle in the heart with potassium chloride, and that stops the heart from beating. So the surgeon bypasses the blocked coronary arteries with a vein taken either from the patient's leg or arteries taken from the patient's chest. And then blood, once that graft is done, they'll start restoring blood to the heart. The heart begins either beating on its own, or they'll use mild electric shocks to assist it. And then the patient is disconnected from the machine, and the doctor closes the chest with wire. So, to better understand this, I have a video, but if you're squeamish, look away because there's blood in a heart. So. Okay, so like with any surgery, of course there's risk with coronary artery bypass, and it's a major surgery. And so there is complications such as bleeding during or after the surgery. There can still be blood clots, infection at the incision site, pneumonia, breathing problems, kidney failure, abnormal heart rhythms, and failure of the graft. And then of course there's always the risk that the patient could still die. But with that being said, there are still benefits to it too. So first and foremost, saving the patient's life. Patients can have bypass surgery and live many years on after that. And it eliminates or reduces discomfort from chest pain. It improves blood flow to the heart. It lowers the risk of heart attack and strokes. And the patient can remain symptom-free for many years. And there's often less needs for blood transfusions and lower death rates. So this brings me to a story. So here I'm pictured with my grandparents. So my grandpa on the right served in the Vietnam War, and if you know anything about the military back then, everybody smoked because that's just what everybody did, and they didn't really know the health effects that it would have. So eventually it did catch up with him, and in his 50s he went in for a cardiac cath for severe chest pain, and things took a turn for the worse, so they had to end up doing an open heart surgery. And he ended up having a heart attack. So then they had to bypass the blockages in his heart. So you can either have like a single, double, triple, quadruple bypass. The absolute max of grafts you can have in a bypass is 7, and that's what my grandpa ended up having. And when he came out of surgery, he was intubated and he had a balloon pump placed for a week. So since it's a major heart surgery and he had 7 grafts, his heart was very weak in the amount of blood it could actually pump. So a balloon pump serves the purpose that when his heart would beat and pump blood, the balloon pump would help pump the blood to his extremities in that. And even though he's had his complications since then, they had given him 3 years to live after the surgery, and now he's considered inoperable since they did the absolute max that they could do. But this actually happened 15 years ago, and this is why I chose to do this topic, and I'm grateful because I got to know my grandpa like I do today. So, any questions?